Hello again. I'm Richard Knight, President of the American Association of Kidney Patients. Thank you for joining us for the 47th Annual National Patient Meeting. As part of the AAKP initiated Decade of the Kidney, AAKP has purposefully targeted kidney research as a strategic priority for involvement and impact. Our national and global patient advocates and affiliates have been actively reaching out to all involved in the kidney science and research enterprise to offer their expertise and insights. At AAKP, we know that medical innovation and public policy are shaped by research, and without patients as active partners, future innovations in kidney disease and kidney disease care would not reflect our practical insights and lived experiences. Further, since research impacts public policy, including regulatory decisions and issues related to what new drugs and devices are paid for by government and private insurance, it is critical that patients work alongside research experts. Again, this is why you see so many messages from AAKP about opportunities to join a research project at a university through the federal government or PCORI. Our goal is to populate and impact every single kidney research project underway in the United States and across the globe. And as you will hear, we have been helped by research professionals in academia and government who want to work with you and AAKP. For today's session, Patient Consumers, Elevating and Including the Diverse Voices of Patients, I'm pleased to welcome several presenters whose work and personal commitment are for greater care choice and ending disparate health outcomes among communities who suffer the most from kidney disease. Leading our esteemed panel is Dr. Jenna Norton, Program Director at the Division of Kidney, Urologic, and Hematologic Diseases at the National Institute of Diabetes, Digestive, and Kidney Disease at the National Institutes of Health. Dr. Norton, I turn it over to you.
Thank you, Richard, and thank you, AAKP, for having me here today. I'm really excited to be here and be a part of this meeting. I'm here today to talk about the ways in which we are rethinking research teams at the National Institutes of Health and the National Institute of Diabetes, Digestive, and Kidney Diseases, particularly with regard to expanding outreach and inclusion in our research. I want to acknowledge that the views expressed in this presentation today are my own and do not necessarily represent the views of the National Institutes of Health or the United States government. Today, we're going to talk about meaningful collaborations with patients and community members, how we're supporting diverse research scientists, and inclusion of diverse research participants in our studies. And I hope that at the end of this talk, you'll leave today realizing that these three things are actually very interconnected and depend on each other to move forward. So first, I'd like to start out by thinking through who do we want to be involved in planning and conducting research. So first and foremost, we want to include people living with NIDDK diseases and conditions. I suspect many of you in the virtual room today. Their caregivers, so the people who are attending appointments with them, family and friends, people at risk for NIDDK diseases and conditions. We also want to think about diverse research scientists in terms of discipline as well as background, community-based organizations such as places of worship, food banks, community centers, and local clinics, because we know these are the places where people are managing their health and their well-being on a day-to-day basis. And of course, other affected organizations such as healthcare, industry, nonprofits, and federal agencies, because getting input from all of these groups ensure that the research that we produce will be useful and implementable in real-world situations. But today, I would like to focus specifically on people living with NIDDK diseases, their caregivers, and people at risk for these conditions. So even though I acknowledged at the beginning of this talk that my views expressed in this presentation don't necessarily represent the views of NIH, I do want to acknowledge that inclusion of patients in the design and development, doing truly community engaged research is a priority for NIDDK. And you can see it right here in our strategic plan. So our scientific goal number 4 in the NIDDK strategic plan is to advance stakeholder engagement, including patients and other participants as true partners in research. This means that we want patients and other community members to help us think through our study designs and make sure they're relevant and appropriate. I also want to acknowledge that this is a priority for the division within NIDDK that focuses on kidney disease. So this manuscript, How Community Engagement is Enhancing NIDDK Research, was put forth by myself and other colleagues in our kidney division at NIDDK, including our division director, Rob Starr. So why do we want to have people, patients, and other community members involved in our research? It's because we believe meaningful collaboration with patients and community can help us do better research. Collaborating with patients can help us identify issues of greatest importance to people with or at risk for the conditions that we research. They can give context to our scientists to help us understand the lives and experiences of those who the research aims to benefit. They can help us develop interventions that are realistic and appropriate to the people who need to participate them, both during the study, which helps with recruitment and retention, as well as after the study, which makes the intervention looked at more implementable for the community. And finally, it helps us to ensure that study populations reflect the people with the disease under study. So how do we go about doing this? How do we collaborate meaningfully with patients and communities? First, we need to earn trust of our community members, especially those who have historically and in some cases continue to be oppressed and disenfranchised by scientific research. We need to educate scientists about the value of community engaged research and how it can make research better produced for everyone. Then we need to train our scientists on how to conduct community engaged research. We need to dedicate time and resources, including compensating patients and community members for their time. We need to incentivize community engagement and funding opportunities. And we need to develop and identify targeted strategies specific to each community. A one-size-fits-all approach will not work. So one example of how we are engaging patients and community members in our research is the Kidney Precision Medicine Project, or KPMP. KPMP aims to understand the mechanisms that lead to kidney disease so we can develop better treatments. This requires us to safely and ethically get kidney biopsies from people with kidney disease. And one of the challenges of the study is that biopsies pose a risk to participants without giving them direct benefits to their health. And so we felt it was really especially important for this study to get input and guidance from our patients and community members. So we include people with CKD, chronic kidney disease, and AKI, acute kidney injury, on our steering committee. And that's the body that makes decisions for the study. There's also been significant intellectual contributions to the study by the Community Engagement Working Group, which is composed mainly of patients. This group wrote the first draft of the informed consent document. They made the case successfully to provide insurance for participants in case of adverse events. They gave input on how to return results to participants in ethically and culturally sensitive ways. And they also gave extremely valuable input on how to communicate with people to get them into the study and to keep them participating. Another example that I'd like to share is our recently released request for applications for interventions that address structural racism to reduce kidney health disparities. This RFA aims to solicit research to develop and test interventions that will dismantle or mitigate the effects of structural racism and reduce kidney health disparities. Some ways in which we have ensured that we will have significant patient and community participation in this research is that we've required applicants to explain how they will facilitate meaningful collaboration and authentic partnerships with patients and stakeholders in their research process. We've also required that applicants should include a community advisory committee comprised of people from the populations most affected by the interventions that they are proposing. And those community advisory committees will give input on study design. You'll be hearing more about this RFA from my colleague Raquel Greer in her talk at this meeting. But I do want to flag while I'm on the subject that we are currently soliciting applications for this RFA, and the receipt date for those applications is November 17th of this year. So thinking again about who we want to involve in planning and conducting research, I hope I've convinced you already that inclusion of people living with NIDDK diseases, their caregivers, and people at risk for these diseases are quite important to include, and that we're making progress on including them more frequently and more meaningfully in research. But now I'd like to shift focus and think about how we are diversifying our research scientist workforce. So we know that there are racial disparities in the way we fund research at NIH. There are also disparities across other lines, but I don't have time, unfortunately, to show all of that data today. Here we can see that the probability of NIH R01 awards by race and ethnicity do vary across our different populations. And after controlling for educational background, country of origin, training, previous research awards, publication record, and employer characteristics, Black R01 applicants, for example, are 10% less likely than white applicants to be awarded NIH research funding. And while this data is from 2000 to 2006, these trends continue, unfortunately. So knowing that we have these disparities in funding is not enough. We also need to take some time to think about why we have these disparities, why we lack diversity on our research teams. A significant contributor to that is structural racism and discrimination. Some examples of this include the way we provide standardized test scores, such as the SAT and the GRE. And it turns out that those are actually better at measuring wealth and whiteness than ability or capacity to succeed in school. There's also a legacy of government-sanctioned segregation through things like redlining that affects access to opportunity, such as education, employment, and social determinants of health. We also have interpersonal discrimination and something called similarity bias. And I group these two things together because even though the intent of interpersonal discrimination and similarity bias are very different. With interpersonal discrimination, obviously, there is a negative intent. But with similarity bias, there's no negative intent or ill will there. However, despite differing intents, they have similar impacts. So similarity bias means people show unconscious preference to other people who are like them. And because cisgendered, straight, neurotypical, non-disabled white men who often hold positions of power may be more likely to hire, mentor, or otherwise give opportunities to other cisgendered, straight, neurotypical, non-disabled white men, this reinforces disparities that already exist, even when there is no intention to do so. So it's also important to consider the benefits of diversity. Now we know that there is this lack of diversity and discrimination in how we award research funding. We know a little bit about why it's occurring, but we also need to know that it's a bad thing to lack this diversity. It actually hurts our science. We know from a relatively large body of research that having more diverse teams improves performance. And you can see to the right of the slide that diversity correlates with better financial performance in business, where the likelihood of financial performance above the national industry mean increases substantially when you're comparing the lowest quartile to the highest quartile in terms of diversity. Diversity also helps generate more accurate and careful thinking. And we believe this is because when you have diverse perspectives, people are more likely to challenge assumptions, and that sort of forces groups to go through a more careful and thoughtful process as they're coming to decisions. Diversity introduces innovation and creativity by bringing different perspectives and new ideas. It also enables more cultural sensitivity and insights into diverse populations when you bring people in who have had the similar lived experiences. And it also allows us to draw from a wider talent pool. If we're only taking our research scientists from a small demographic area, we may be missing the talent and the skills that come from the diversity of the people within our country and within our potential research pool. So how are we addressing the lack of diversity in our investigators at NIH and NIDDK? One example I'd like to discuss is the Plan for Enhancing Diverse Perspectives. This concept came out of the BRAIN Initiative, but we've also been beginning to use this in our NIDDK research as well. The Plan for Enhancing Diverse Perspectives is a one-page document that must be submitted with each research application, and it describes the applicant's strategies to advance scientific merit through inclusivity. In this context, diverse perspectives refers to who is conducting the research, so who in terms of their social background, including those underrepresented in the research workforce, who in terms of their different scientific disciplines are conducting research. So we want to include our basic scientists and our clinicians, but we also want to expand beyond that to think about people like social workers and public health professionals and patients to be part of the research team. And it also wants us to consider varying career stages, skills, experience, and expertise. Diversity also here refers to where the research takes place. So in traditional spaces like academic institutions and minority serving institutions, but also less traditional spaces like community-based organizations. And finally, the plan applicants to think about diversity in terms of who is participating in the research, in terms of the study population, to make sure that the population is appropriate to the research question being asked. Another example of how we are trying to foster more diverse research teams is, again, in our Interventions that Address Structural Racism to Reduce Kidney Health Disparities RFA, which is out right now. This application requires a plan for enhancing diverse perspectives, the plan I just talked about on the prior slide. And we've set up the RFA such that this plan will be assessed as part of the peer review for the application submitted to this RFA. We also explicitly in the RFA encourage a multidisciplinary research team with relevant expertise that spans nephrologists, social scientists, behavioral medicine, health equity and disparities researchers, public health practitioners, biostatisticians, ethicists, clinical trialists, people with kidney disease and their caregivers, community-based organization representatives, and the many other people involved in the health and well-being of people with kidney disease. The RFA also requires that at least one principal investigator have substantial experience in community-engaged health equity research. And lastly, I would just like to very briefly touch on the inclusion of diverse participants in research. Due to the short length of this talk, I don't have time to get into detail on this as much as I would like, but I do want to acknowledge that study populations should reflect real-world populations. So if we are doing a study on kidney disease, the people in our study should look like, demographically speaking and regionally speaking, should look like the people in our country who have kidney disease. Just like community-engaged research, inclusion of diverse participants requires building that trust, which again has previously been broken for many of our communities. It also requires study designs and interventions that are realistic and palatable to the people affected by them. And I believe we will better be positioned to include diverse participants if we pursue community and patient-engaged research approaches, because that's how we understand and know what will be realistic and palatable for our potential participants and the people most affected by our interventions. And I also believe that it will be facilitated by having diverse and inclusive research teams who can bring the perspective of diverse lived experiences to the research context. So I want to thank you again for having me here today. I hope you found this talk helpful. If you have any questions, please feel free to reach out to me. I put my email address on the slide. Please again, reach out with any questions. Thank you again for having me.
Thank you, Dr. Norton, for an excellent and very informative presentation.